Welcome to our live webinar titled Long-Term Survivors, Bone Disease After Transplant. Thank you for joining us. My name is Lee Clark, patient educator, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of Bristol Myers Squibb, Jazz Pharmaceuticals, Alexion, Agios, Apellis, Genentech, and Takeda Oncology, and the generous support of our patients, families, and caregivers for supporting the webinar program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the webinar. If you are unable to view the webinar online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or a comment, open the Q&A window in the lower part of your screen. Type your question in the small text box window, and when you have finished typing, just hit enter. We will do our best to get to all the questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming questions. Please submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Holly Comer. She has been an oncology nurse for over 30 years and has been a nurse practitioner for the last 14 years. Ms. Comer is with Siteman Cancer Center at Barnes-Jewish Hospital and Washington University School of Medicine, where she has been part of the bone marrow transplant team for the last 26 years. With that said, welcome, Holly, and thank you for joining us today.
Thank you for having me. Am I on now? This is my first webinar, so bear with me, everybody. Good morning to all. Next slide. Okay, I no longer have disclosures because I no longer do speaking in person anymore, so we can move on to the next slide. Okay, I am going to talk about endocrinopathies and bone disease after allogeneic transplant. As Lee said, I've been in transplant for over 30 years, and so we're going to go into a little bit of the background of allogeneic transplant and a little history. So autologous and allogeneic transplants were started in Europe approximately 5 decades ago. In 2017, in the U.S., we had 9,000 allogeneic transplants from unrelated donors or siblings. And some of the background of why we're talking about this is a retrospective study of over 1,000 survivors shows the cumulative incidence of non-malignant late effects at 5 years post-allogeneic transplant was 79%, with approximately a fourth of these people have 3 or more late effects. And one of the endocrine system is one of the most frequently targeted post-transplant complications. And so we will start with endocrinopathies. So next slide, please. So just a few definitions so we're all on the same page. And we're going to talk a little bit about normal endocrine functions so you can understand when the normal function first, so you can understand when it's dysfunction. So an endocrinopathy is just a disease marked by dysfunction of an endocrine gland. Next slide. The endocrine system consists of a group of glands and organs that regulate and control various body functions by producing and secreting hormones. So these hormones are chemical substances that affect the activity of another part of the body. In essence, they serve as messengers, controlling and coordinating activities throughout the body. So next slide. So endocrine glands, these are a list of the endocrine system, the major glands of the system, the hypothalamus, pituitary gland, thyroid, parathyroid, islet cells of the pancreas, adrenal glands, testes in men, and ovaries in women. Next slide, please. I am going to go over this slide in pretty much detail because it really kind of is a good overview of how the endocrine system works and how complicated it is. And so you can see that a lot of things can go wrong, especially after chemotherapy, after medications, after allogeneic transplant. And so the hypothalamic-pituitary axis, so the hypothalamus secretes and releases inhibiting and stimulates and inhibits production of hormones. So if you look on the, I'm starting on the left-hand side as I look at the screen. So these neurosecretory cells produce and release inhibiting hormones. They're secreted into the portal system, and then each type of hypothalamic hormone either stimulates or inhibits production and secretion of an anterior pituitary hormone. So the anterior pituitary hormones are FSH, LH, growth hormone, prolactin, ACTH, and TSH. And we'll go into a little bit more detail in a minute. Then if you look at the right-hand side, those neurosecretory cells produce ADH and oxytocin. So the posterior and the anterior pituitary are the ones releasing these hormones. Next slide. So we're looking at specifically the hypothalamus-pituitary thyroid axis, which is one that's frequently disrupted after allogeneic transplant, and people end up on medications, and we'll talk about that in a little bit. But the normal hypothalamus-pituitary thyroid axis, the hypothalamus releases TRH, which then in turn stimulates the anterior pituitary, which in turn releases TSH, which stimulates the thyroid gland, which then releases T3 and T4, which has a negative feedback, which then shuts off the anterior pituitary. So that is a normal cycle of the pituitary thyroid axis. Next slide, please. So this is the hypothalamic-pituitary-adrenal axis, and kind of in cartoon form, but makes it perhaps a little easier to understand. Stress causes the hypothalamus to release CRH, which stimulates the anterior pituitary to release ACTH. So that was the one on the right side of the axis. So that in turn, the ACTH stimulates the release of cortisol from the adrenal cortex, which sits on top of the kidneys. So this cortisol raises the glucose levels and provides negative feedback, thus shutting off the hypothalamus and the pituitary. So this is the normal way that some of our endocrine system works. Next slide, please. Now we'll kind of we will switch over to endocrine diseases. So what happens when these organs dysfunction? So we will discuss thyroid dysfunction, gonadal dysfunction, diabetes, dyslipidemia, metabolic syndrome, and adrenal insufficiency. Next slide, please. So hypothyroidism occurs in almost half of irradiated patients and 30% of all allogeneic patients. So you can see this is a huge problem. It also sometimes does not show up until years after transplant. So sometimes it's not on people's radar. And a lot of times the side effects when patients come in, my patients come in, they often have symptoms of fatigue and inability to like get up off the couch and do things, and it can become very debilitating, and so it is very treatable. So we want to always look for this, especially years out of transplant. So testing includes TSH, free T3, and free T4. So the treatment consists of Synthroid, and which is a daily oral supplement, and has to be adjusted according to the level in your blood. So we usually check the level about 6 weeks after starting the synthroid, and then periodically every couple months to make sure that it stays in the correct level. So gonadal dysfunction occurs in approximately 90% of women and 70% of men with low incidence of recovery. So that testing includes testosterone, estradiol, LH, FSH. And the treatment consists of embryo freezing, sperm baking. There's also testosterone supplements and estrogen supplements that are available. So moving on to diabetes plus glucose intolerance is estimated to occur in 11% of allogeneic patients at 5 years and 69% at 10 years. So this is a huge problem also after allogeneic transplant and often caused by steroid use. So testing includes glucose levels, hemoglobin A1C, and treatment includes oral anti-diabetic agents, perhaps insulin, lifestyle changes, exercise, statins, fibrates. Diabetes, of course, is a problem within the United States, not only in allogeneic transplant patients, but in the general population. Next slide, please. Dyslipidemia occurs also in approximately half of allogeneic transplant patients. So the testing includes triglycerides, cholesterol, HDL, LDL, fasting blood glucose. Treatment includes statins, fibrates, lifestyle changes. And you'll see a lot of these treatments overlap one another because a lot of these metabolic syndromes overlap each other. So the last one is called metabolic syndrome, which is includes hypertension, diabetes, high cholesterol, obesity, and occurs in almost half of transplant patients. And again, we look at blood pressure readings, hemoglobin A1C, HDL, LDL, and treatment includes treating the hypertension, the diabetes, the high cholesterol, and dietary changes with weight loss. Next slide, please. So adrenal insufficiency occurs in approximately 13% of patients after allogeneic transplant. The testing includes ACTH stimulation, which is an IV administration of 2,050 grams of an I-24 corticotrophin to test the adrenal glands, which sit on top of the kidneys. It's an IV administration which looks at the lack of stimulation is defined as an abnormally low baseline blood cortisol level that does not rise above 20 grams per deciliter and does not double in the hour following ACTH injection. So how we treat that includes steroids twice daily, usually a low dose, approximately 5 milligrams of prednisone, that is very slowly weaned off over several months to a year. Okay, next slide. We're going to switch gears a little bit here. Now we're going to look at bone disorders following allogeneic transplant. So again, we're going to go over the normal bone function so we can understand when it is misfunctioning. So normal bone function, you have osteoclast and osteoblast, which is a combination. They work together for normal bone growth. So osteoclasts is have the function that disrupts the old bone tissue. It disrupts the old bone tissue so the osteoblast can function to produce the new bone tissue. So it's a constant turnover of old bone tissue being replaced by new bone tissue. And next slide, please. So it's a cycle that works together using bone resorption and bone formation. So this is important with the way medications work to fix bone problems following allogeneic transplant. So next slide, please. So in normal bone growth, we have increase in bone density that peaks for males and females about mid-30s. So that is your best bone mass. And then after that, you start to lose bone mass the older we get. Especially in women, it happens faster due to menopause. And so men tend to have a lower loss of bone mass than women. But we all start to lose bone mass in mid-30s. So if you have an allogeneic transplant, that speeds up that bone destruction by approximately 50% in the first year. So a huge difference between the general population. Next slide, please. So we're going to look at osteopenia, osteoporosis, and avascular necrosis, which are the bone disorders after allogeneic transplant. So first, osteopenia. Next slide, please. That's a mild thinning of the bone mass, not as severe as osteoporosis. It results when formation of new bone is not sufficient to offset normal bone loss. Next slide, please. So it's actually an overgrowth of osteoclasts. So osteopenia means you have more osteoclasts and not enough osteoblasts to have that new bone formation. So you can see the normal bone, how it's kind of dense looking, and then the osteopenia bone has more holes basically in it, so not as dense tissue. Next slide, please. So osteoporosis is a worsening condition of osteopenia in which the density and quality of bone are reduced even more from osteopenia. Next slide. So you can see here, again, the normal, closer up view of the normal bone density and the osteoporosis, which has increasing holes in it, so not as much density, near as much density as a normal bone. Next slide. So how we measure this is with a DEXA scan. So that's an image that measures bone density, the amount of bone mineral contained in a certain volume of bone, and they pass x-rays with 2 different energy levels through the bone. And it's used to diagnose osteopenia and osteoporosis, also called bone mineral density scan, DEXA scan, dual energy x-ray. Next slide, please. So when you get the results of that, and I'm sure you guys are probably familiar with this, it's a T-score, which is how they measure the bone density. And so you have a T-score of either less than 1 and above, considered a normal score, or between -1 and -2.5, and that's classified as osteopenia, or low mass. And then below -2.5 is osteoporosis, or extremely low bone mass. Next slide. So osteoporosis occurs in, again, approximately 50% of transplant patients. It occurs within 6 to 12 months following transplant, and use of corticosteroids is the strongest risk factor for osteoporosis. So because of this data, slowly we're kind of changing our norm. We are looking at DEXA scans now. We used to just look at them maybe a year post-transplant, but now we're looking at them pre-transplant and comparing it with 6 months and a year post-transplant, knowing that in that time period you're going to have the greatest amount of bone loss at that time. And next slide. So because of this, there are pharmacologic treatments, but there's also non-pharmacologic things that we can do to improve our bone density. So that includes weight-bearing and muscle strengthening exercises, which I can't stress enough how important that is for not only transplant patients, but all of us. Cessation of smoking, decreased alcohol consumption, calcium, vitamin D supplementation is very crucial. Looking at our own data from our own patients, we tracked our transplant patients for a year and found that their calcium vitamin D was low in almost 95% of our patients. So it becomes important for almost all of our patients to get calcium vitamin D. Listed below are the normal doses, but sometimes vitamin D is very low in some patients, lower than 25 or so. If it's lower than that number, we give a higher dose vitamin D supplementation of 50,000 units weekly for 12 weeks and remeasure the level at that time. Still, if they're still low, then we would continue the higher dose supplementation. Next slide. So now we'll look at the pharmacologic treatments of osteoporosis. So biphosphonates are by far the most commonly used in our patients, but there are also some newer ones that are they're being used or under study. So these include, and we'll go over each of these, a RANKL inhibitor, estrogen agonist, parathyroid hormone analogs, and calcitonin salmon. Next slide, please. So how these treatments work. So they either inhibit bone resorption or stimulate bone formation. So either they're going to inhibit the osteoclast or promote the osteoblast, basically. So the most common that we use are the osteoclast inhibitors. So those include the biphosphonates, the estrogen agonist, calcitonin, and the inhibitors of RANKL. Next slide, please. So that's how biphosphonates work, is they actually cause the apoptosis of the osteoclast, thus making it easier for the osteoblast to put down new bone. So they work very well and are by far the most commonly used. Next slide, please. This just lists the most common biphosphonates used. We use zoledronic acid probably the most, and we have looked into some studies about even giving a dose of zoledronic acid prophylactically before transplant, which has been done very rarely, but in a few centers, with some good results. So that moving forward, it might be some way to prevent bone loss prior to transplant, which so far has not been done universally. Next slide, please. PROLIA, which is a RANKL inhibitor, is one of the newer ones on the market. It also inhibits osteoclast formation by a different mechanism. Next slide, please. So it is called a rank ligand inhibitor, human monoclonal antibody. So that is kind of the mechanism of how it works. It's subcutaneous injection twice yearly. It inhibits bone resorption, or the osteoclast activation, and it's more potent than biphosphonates, thus needing it only twice yearly. Next slide. So the estrogen agonist is also osteoclast inhibitor, and these include, next slide, these two are raloxifene and conjugated estrogens. These have some side effects of maybe causing blood clots, so may not be good for all patients, only in a certain patient population. So next slide, please. Parathyroid hormone analogs is a recombinant human PTH analog. So this mimics the physiological action in stimulating new bone formation. So this is working on the other side. It's promoting osteoblastic activity. So this, though, does have side effects, and so you can only use it up to 2 years due to increased incidence of osteosarcoma in rats. So there's also another new recombinant PTH that but cannot be used if people have pre-existing hypercalcemia. So another option for people moving forward, but does have some side effects. So next slide, please. So there are some emerging therapies coming out that are, also looking at different ways to promote bone growth. So romosozumab, I'm probably mutilating that name, is a human monoclonal antibody that inhibits sclerostin. So sclerostin is a protein secreted by osteoclasts to reduce bone formation, interfering with the proliferation and function of osteoblasts. So if you inhibit the sclerostin, then you would promote osteoblast formation. Lisofosine is a third generation of this kind of drug. Next slide, please. This is just a picture of the way sclerostin inhibition works at the nuclear level that increases bone formation. So next slide, please. So the last thing we'll talk about in bone disorders is avascular necrosis. This occurs in 4 to 19% of allogeneic survivors and can be very debilitating and painful. It causes bone pain and destruction by disrupting the blood flow to the bone. It's diagnosed by an MRI, and the treatment consists of joint preserving surgery and joint replacement surgery. Next slide, please. This is just a picture of how a necrotic bone looks with loss of blood flow to the area. So it shrinks down and becomes necrotic bone. Very painful disorder, as people who've had it know, and can be extremely debilitating. Next slide, please. So in summary, this is it's important to monitor pertinent lab work and scans post-transplant, especially in the first year when a lot of these acute problems can happen and be very debilitating. And moving forward, we're looking at more prophylactic measures that instead of waiting for a problem to happen, perhaps we can prevent it early on and make people's life post-transplant more tolerable with less problems. And regular follow-up is important because, as you can see, early detection is going to make fixing the problem much easier. And we also need to establish or build relationships with our primary care physicians who work with us in taking good care of our patients. This is the end of my presentation. I'm happy to take any questions.
Thank you so much, Holly, for the wonderful presentation. We have a few questions. Are there special doctors or nurse practitioners patients should see for follow-up long-term who are trained to look at these long-term effects?
Yes, very good question. We do use the endocrine department because a lot of these problems overlap. You know, people have diabetes, they have bone problems. So an endocrinologist deals with all of that. So we almost universally use an endocrinologist to help us treat patients, which I think is very important, and primary care physicians. Also managing diabetes, heart problems, hypertension, you know, a lot of these problems that occur post-transplant.
So it's recommended to have an endocrinologist on your team post-transplant, or should you consult one pre-transplant?
So sometimes we do consult pre-transplant if we find that people start out with osteopenia or osteoporosis even prior to transplant. Then we loop in the endocrinologist at the very beginning to help us, because we already know they're going to have bone loss in that first year anyway. So we want to loop them in as quickly as possible and have a referral so we can be more proactive instead of reactive, which is traditionally how we've been.
Thank you. Is it recommended that patients have a DEXA scan prior to going into transplant to determine if they already have some type of bone loss?
Yes, I think that is becoming more standard of care throughout the country, that people are starting to concentrate more on bone health. As I said, we used to at the very beginning just kind of look at it a year or so out, but by that time the damage is done. You know, we're just backtracking. So we have found in our looking at research that a lot of big institutions are doing DEXA scans prior to transplant to have a comparison.
Thank you. Does the intensity or the type of pre-transplant conditioning have an impact on who will develop bone disease?
Yes, some, and I don't have a list of those with me, but yes, some are more, tend to be more destructive on your bone health than other kinds of conditioning regimens. So I specifically don't have a list of those, but definitely the conditioning regimen makes a difference.
Okay, thank you. How will a transplant impact somebody who is already diabetic?
So that's a good question. A lot of times the diabetes gets worse because of the steroids and some of the medications we use. So a lot of people end up, even if they were only on maybe metformin prior to transplant, they often end up on insulin, at least for a while post-transplant, because it becomes hard to control the diabetes. So a lot of times people are on high doses of insulin.
Thank you. Are there any markers that would indicate someone's predisposition to bone disease?
Not that I know of. We don't have any standard testing. I mean, if people have a lot, like when you have a DEXA scan, they ask you several questions like, do you smoke? Do you have a history of diabetes in your family? Do you have a history of taking steroids? So some behaviors prior to transplant will affect your bone health, and they ask those questions prior to doing a DEXA scan, and which does kind of put you in a different risk stratification.
Thank you. Does the type of disease you received the transplant for have an impact on the likelihood of developing bone disease?
Not that I know of. I've not read anything about that. Not to say that maybe there is and we just haven't studied it. But I don't know of a direct correlation.
Thank you. Do children have the same possibility of developing bone disease after transplant?
I've not studied the pediatric populations, so it would be hard for me to answer that question. I would have to look into that patient population.
Thank you. This question comes from an aplastic anemia patient who was treated with ATG and cyclosporine many years ago, and they're now looking to have a transplant. They'd like to know, does the previous treatment of cyclosporine for many years, will that have an impact on their possibility of developing bone disease?
I don't think so. And again, I've not seen that specific patient population was studied. So I wouldn't have hard data to back up that answer. But we have had a lot of patients treated with those medications and go on to transplant and seem to be at the same risk as other people. Does not seem to make them more at risk. But I'm not sure that it's really been accurately studied to give really hard data on that subject.
Thank you. If you do not have diabetes and the disease is in the family, are there risks of getting diabetes still present after transplant, or is diabetes a common thing after transplant?
Diabetes, unfortunately, is a common thing after transplant, but especially if you have a strong family history, it can be even more of a problem post-transplant, but it does occur in a relatively large population, probably because of steroids, and approximately 50% of transplant patients get graft versus host disease, requiring steroid use and sometimes very high steroid use, and that seems to be the biggest risk factor.
Thank you. The use of preconditioning chemotherapy can put women into early menopause. Is it recommended that they use estrogen to help with these side effects of menopause?
So we usually recommend to a gynecologist because that's such an ever-changing field, and we specifically don't keep up with the estrogen kind of treatments for postmenopausal women. So we usually always refer to a gynecologist.
Well, thank you very much. And that's all of the questions that we had for today. So thank you, Holly, for taking the time today to share your time and your expertise with all of us. If you'd like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If you were not able to ask your question today, you can send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit a question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure disease. The AAMDSIF Medical Advisory Board and team are here to help you and your family as we have done for the past 36 years. This concludes today's program. Thank you.